The programs have at least 4 benefits, I think. They reduce the pressures for antibiotic resistance. They reduce cost. They reduce complications. Less antibiotics, less antibiotic complications. And Clostridium difficile is now the #1 hospital-acquired pathogen, and that's driven to a large extent by antibiotic use, and some people think particularly fluoroquinolone use and cephalosporin use. I think it makes life easier for physicians if they're given some guidance on how to treat. And I know I'm an infectious disease physician, and if someone that I see in the hospital has some complicated cardiac problem, I would rather have something spelled out for me in terms of what the current guidelines are than have to go hunt it all down. So in-time information about appropriate prescribing, and particularly infectious diseases where resistance changes and treatment changes, and every year since I've been out in the past 40 years, there's been a new disease and many changes in drugs available. There's cost to it. So if you're doing prospective audit and feedback, that's costly. It means someone has to do the work. If you're an infectious disease physician and you're seen as a policeman and you're in a private hospital, there's always a concern about referrals, that people won't, you'll anger too many attending physicians, which I think is usually not the case. Usually physicians are thankful and appreciate the help. So I think it's an issue of cost, and some hospitals, physicians tell me, would be just as happy to have you use a generic drug compared to a brand name drug and save that money rather than use no drug at all. And sometimes these patients don't need drugs at all. That is a big concern, is that big hospitals versus little hospitals, single physician practices versus multi-provider practices versus some of these quick outpatient clinics that are in retail chains, that some of them are algorithm driven and never see the patient again. Others have established relations, and the patient can call you back if they're not doing well. So you think they have acute sinusitis, it's probably viral, they're in day 2 of illness, you say antibiotics are not appropriate, call me in 7 days and we'll see how you're doing. So I think, yes, it is very different, and I think that's one of the challenges to the regulators, to figure out how to deal with different size hospitals so that they're not having unreal expectations. I think that is a work in progress, but I think that is a big problem. The feds are going to probably mandate for inpatients antibiotic stewardship, and for outpatients, the CDC is looking at an aggressive program to work with physicians and physician organizations to give defined upper limits to antibiotic use. So for example, in adults, pharyngitis is group-based strep in about 10 or 20% of individuals at most, but 60% of adults, if they come in with a diagnosis of pharyngitis, get an antibiotic. So the question would be to push that 60% down closer to the 10 or 20% and have sanctions for programs that don't do that, and have encouragements for programs that do. So it's a question of the carrot and the stick.